Our next presenter is Dr. Stacey Tarvin. So Stacey is an assistant professor of clinical pediatrics at Riley Hospital for Children in Indiana. She's holds a couple of important positions at CARA in JDM research and the JDM therapeutics group. She's a member of the Press JDM Working Party. In Riley, she leads clinical research efforts focusing on clinical trials, registry studies, and investigator-initiated projects. Her main research focus is therapeutic consensus treatment plans and telehealth in JDM. And Stacey's going to talk to us today about JAK stats and TYK2, something that we know is all near and dear to our hearts and has already come up in several presentations already. So Stacey, over to you to unravel this for us.
I'll do my best. Can everyone hear me clearly, and can you see my slides?
Yes.
Perfect. Thank you, Andrew, and thank you to the CureJM group for the invitation to present this information. I am thrilled to be a part of this illustrious group of presenters and have really enjoyed the talks to this point. These are a few of my disclosures and some objectives for the talk. So I'm going to discuss the role of interferon in the pathogenesis of IIM, describe the JAK-STAT pathway and how cytokines lead to inflammation, review existing pharmacologic therapies targeting the JAK-STAT pathway as they pertain to DM and JDM, and outline the reported JAK inhibitor use in DM and JDM. A couple of notes. I'm going to talk about off-label use of JAK inhibitors, and this is meant to be a general and not a comprehensive review in 20 minutes. As we know, IIM are a heterogeneous group of disorders affecting largely skeletal muscle, but that can affect multiple organ systems, including lungs, skin, GI tract, and joints. The 2017 EULAR-ACR classification criteria identifies 6 different phenotypes: polymyositis, inclusion body myositis, amyopathic dermatomyositis, dermatomyositis, juvenile dermatomyositis, and juvenile dermatomyositis other than JDM. Today, as a clinical pediatric rheumatologist, I am focusing this talk primarily on JDM in my review of the use of JAK inhibitors in this disorder. Even now, steroids remain a mainstay in therapy, and steroid-sparing agents, while numerous, have little data to allow for a treat-to-target approach. Few drugs are FDA approved for treatment, and patients bear the risks and comorbidities associated with long-term uses of steroids and other immunosuppressants. Understanding the pathogenesis of this disorder is critical to promoting precision medicine for the diverse phenotypes seen in IIM. The pictorial on the top left shows some of the typical features associated with JDM, and Figure 1 is a very recent publication outlining the proposed and critical role of type 1 interferon in the pathogenesis of skeletal muscle inflammation seen in this disorder in JDM. I'm going to review the basics of these pathways because understanding those basics can help us understand, anticipate, and choose therapies that are most appropriate for the patients who sit in front of us. The clinical manifestations of dermatomyositis are associated with abnormalities in innate immunity, in particular overstimulation of the interferon pathway, as we've heard from multiple presenters today. Interferon as a term was coined in 1957 when it was observed that cells previously infected by a virus could produce a substance, interferon, that made other cells immune to different viruses. Thus, interferons are antiviral cytokines, or host-derived signaling proteins. And while we've talked a lot today about interferons in a very targeted manner, it's important to remember that they have many roles, including antiviral, antiproliferative, and immunomodulatory functions. Interferon alpha is produced by macrophages, lymphocytes, tumor cells, cells infected by viruses or affected by mitogens. Interferon beta is produced in epithelial cells and fibroblasts, and production is triggered by viruses. Interferon gamma is produced by T cells and natural killer cells after stimulation by external mitogens. And Dr. Worth highlighted that both interferon beta and gamma are elevated in skin disease. These cytokines bind to the receptors on the cell surface and activate the Janus kinase single transducer and activator of transcription, or JAK-STAT, signaling pathway, leading to expression of interferon-inducible genes. Many cytokines regulate the immune system through these pathways, including erythropoietin, growth hormone, interleukin 267, and obviously interferon. Interferons activate the JAK-STAT pathway. This pathway refers to molecules mediating a widespread intracellular signaling pathway, physiologically involved in many processes, including hematopoiesis, adipogenesis, apoptosis, and immune response that influences both the innate and adaptive immunity. Aberrant activation of the pathway is associated with autoimmunity and carcinogenesis. The JAK family is composed of 4 proteins, JAK1, 2, 3, and tyrosine kinase 2, or TYK2. The STAT protein family activates transcription proteins and is composed of STAT 1, 2, 3, 4, 5A, 5B, and STAT 6. JAK3 only binds to one receptor subunit in the common gamma chain. Binding in the classical pathway, depicted by the animation that just came up, leads to phosphorylation of cytoplasmic transcription factors STAT1 and STAT2, which forms a heterodimer that translocates to the nucleus, leading to activation of interferon-stimulated genes. In the pathogenesis of dermatomyositis and JDM, upregulation of interferon alpha and beta inducible genes and proteins are highly implicated, where overexpression of these proteins is identified in muscle, skin, and blood. Additionally, expression of interferon inducible genes correlates with disease activity, both in DM and JDM. Importantly, JAK2 interacts with growth hormone receptors and prolactin, important when considering growth and development in children exposed to JAK2 inhibition. JAK3 is mostly involved in negative selection and production of lymphocytes, present only in bone marrow and lymphoid tissue. The JAK-STAT pathway is increasingly a target of pharmacologic therapies. JAK inhibitors are small molecules that are largely shelf-stable, oral, and may cost less to produce than biologics. JAK inhibitors were initially approved for treatment of rheumatoid arthritis. First-generation JAK inhibitors are non-selective, including tofacitinib and baricitinib. Tofacitinib was approved by the FDA in 2012 for RA and ulcerative colitis, was the first JAK-STAT inhibitor to be developed, and binds JAK1 and 3 pathways, and was shown to impair Th1 and Th2 differentiation, as well as production of Th17 cells. So there is strong activity in JAK1/3 with minor activity in JAK2 and TYK2. It's postulated that the JAK3 inhibition in particular is the likely source of the heme-related side effects seen with the use of this drug. This is in contrast to baricitinib, approved in 2018 for rheumatoid arthritis, which inhibits JAK1/2 strongly with modest TYK2 activity and weak JAK3 inhibition. Ruxolitinib, approved for myeloproliferative diseases, graft versus host disease, and rheumatoid arthritis, blocks the interferon pathway, inhibiting JAK1 and JAK2 signaling. Newer generation JAK inhibitors display greater selectivity for JAK1, thus potentially mitigating side effects seen in less discriminative compounds. The first case report using JAK inhibitors in dermatomyositis was published in 2014, nearly 10 years ago, in a patient with long-standing dermatomyositis who developed myelofibrosis and was treated with ruxolitinib, for which it was FDA approved. The myelofibrosis improved, but so did the clinical features of the dermatomyositis, leading to the premise that blocking activation of JAK-STAT pathway with JAK inhibitors caused downregulation of the inflammatory cascade. Many early reports of highly refractory patients, including those receiving multiple medications, and after use of JAK inhibitor, multiple clinical features, skin strength and arthritis, all improved. Pike, in a 2018 trial, and Landislau in the same year reported cases that showed an increase in interferon-induced chemokines, decreases in interferon-induced chemokines, CXCL9 and 10, also highlighted in Dr. Jansen's talk today, and serum interferon levels decreased respectively with the use of tofacitinib and ruxolitinib. In JDM, early reports of use of ruxolitinib and baricitinib in extremely disease-refractory patients showed STAT1 phosphorylation decreased to levels similar to controls in conjunction with significant clinical disease improvement. Presently, the JAK-STAT inhibition in DM and JDM is recognized in several clinical scenarios, including recalcitrant skin disease, specifically calcinosis, and an MDA5-associated ILD. However, the cumulative number of patients reported in both adult, 46, and pediatric, 11, populations has been very small and suffers from tremendous bias. In 2022, authors in China reported the largest pediatric cohort of JDM patients treated with JAK inhibitors. This publication reported two things. One, a retrospective cohort study evaluating JAK inhibitor use in JDM patients, as well as a cross-sectional study of cytokines in those patients treated with JAK inhibitors from 2017 to 2021. 23 of the 100 patients reported were treated with ruxolitinib. The remaining 77 were treated with tofacitinib. The top two reasons to use JAK inhibitors were to control rash and decrease glucocorticoid use. Myositis-specific antibodies were reported, with 18% having NXP2 positivity and 5.4% with anti-MDA5 antibody positivity, and smaller numbers of other myositis-specific antibodies. Median follow-up time was 18 months. So this is one of the result tables, and I want to highlight a couple of things here. Most importantly, that there was, even though in some small numbers, especially with regard to muscle strength as assessed by the CMAS, significant seen an improvement in skin score strength, monitoring of LDH, and importantly, the glucocorticoids were stopped in 40% of these patients. Adverse events were reported, including 15% that had reportable leukopenia, but none to the extent that they discontinued the medication due to that leukopenia. Hemoglobin and platelets were monitored throughout the trial, and no abnormalities were reported there. 19% of patients reported a quote-unquote non-productive cough, with 27% reporting a respiratory infection occurring within 6 months of initiating treatment with a JAK inhibitor. Of the infections also reported, 7 cases of EBV and CMV, 2 of herpes zoster. There were no thrombotic or cardiovascular events. Of note, many of these patients were already undergoing treatment at the time of cytokine analysis, and COVID-19 outbreak affected follow-up rates. So the key messages from this trial, which was the largest report in pediatric use of, or the largest report of retrospective cohort study of use of JAK inhibitors, was that the long-term use of JAK inhibitors was shown to be effective and safe over 100 JDM patients. In their cross-sectional study of cytokines, they assessed a 6 cytokine panel that could be assessed to show sensitivity and specificity that was predictive of active JDM. And that one of those cytokines, IL-1RA, changed dramatically in active patients, reaching over about 800 times the mean normal values. We've talked a lot about the JAK portion of this story, but what about the STAT portion? The JAK1, STAT1, STAT3 axis is pivotal in the physiology of skeletal muscles. This pathway promotes myogenesis. The JAK2, STAT2 axis leads to the opposite effects, and it's associated with TGF-beta and IL-6, which produce pro-fibrotic and pro-inflammatory effects, leading to, among other things, interstitial lung disease. STAT3 is activated by all of the cytokines displayed here and plays a pivotal role in multiple organ systems, including those most targeted to IM. And you can see in this figure that STAT3 in particular is associated with stopping myogenesis, premature formation of myotubes, potentially affecting muscle atrophy and muscle wasting, increased migration and proliferation of keratinocytes, leading to aberrant wound healing, as well as cutaneous rashes, collagen deposition by myofibroblasts, including causes of fibrosis, as well as activation of early growth response genes in the pulmonary vasculature. Newer JAK inhibitors, some of which are displayed here, are more targeted in particular to JAK1 as mentioned. And some of these include, and I'm not going to get all these names right, I apologize, baricitinib and filgotinib, which have both been approved for rheumatoid arthritis, where they have been shown to have safety and efficacy, and fedratinib, which was approved to treat myelofibrosis and is specifically a JAK2 inhibitor. This leads us to talk about the published clinical trials in the use of JAK inhibitors in IIM. This article published by LaRocca and colleagues, the clinical trials are outlined as published by March of 2023. Improvements are highlighted in skin disease and interstitial lung disease. In summary, there have been 3 trials for tofacitinib, 2 in baricitinib, and 1 in ruxolitinib in adult DM, outlining these specific subtypes. The table here depicts the ongoing clinical trials as of March 2023, looking at multiple agents targeting various portions of the immune system. You could see 2 ongoing trials looking at JAK-STAT targets. And this one that says not yet recruiting started recruiting in May of 2023. So in preparing this talk, I ran across a e-published, not yet fully published, very nice review done by Dr. Batu and colleagues that looks at treatment with Janus kinase inhibitors in juvenile dermatomyositis. So what about pediatrics? This is the Prisma diagram that looks at the studies that were identified as describing use of JAK inhibitors in any sort of way in pediatric dermatomyositis. As you can see, they found 26 articles reporting 195 JDM patients treated with JAK inhibitors. This is the abstract slide associated with the publication, and I'll walk through it briefly for you. So as mentioned, 195 patients were described as being treated with JAK kinase inhibitors. Tofacitinib was 112, ruxolitinib 53, baricitinib 30. The indications for treatments consisted of skin involvement, muscle involvement, pulmonary involvement, calcinosis, joint involvement, cardiac involvement, macrophage activation syndrome. And when reported, significant improvements were reported. The adverse event is listed here, but I wanted to dive a little bit deeper into this article. And so I summarized one of the response charts to make it a little bit easier to view today for this presentation. So in looking at the summary of reports of JAK inhibitor use in JDM, in terms of the 3 JAKs used, we have tofacitinib, which is largely a JAK1/3 inhibitor, ruxolitinib and baricitinib in fewer cases, largely JAK1/2 specific. The treatment duration for the use of each of these amounts to about a year to a year and a half of exposure. And the treatment indications are listed here in those patients that had that reported. Average age of the patients at the time of the use was about 5 years of age, interestingly, and disease duration was about a year and a half. Much of the data is not reported or listed as NA throughout the publication. And adverse events are listed in the article only for the tofacitinib cohort. So that's what you should focus on, and are most significant for upper respiratory infections. And unlike the slide, the summary slide that's listed, of those patients who had reported data, 51% reported upper respiratory infections. Probably not out of the range for patients who are 5 years of age who are on systemic immunosuppressants, but important to recognize. Additionally, a definition of improvement is not well outlined or defined here. And there are many other considerations. Interestingly enough, when you look at the indications for treatment and responses, the second column on the right, which is what was reported for tofacitinib, most patients were reported to have had good improvement, but of course there's a lot of bias associated with this. And this also documents, interestingly, relapse under treatment, which seem to be pretty small, although seem to be underreported in a lot of these groups. So in summary, interferons in the JAK-STAT pathway play a critical role in inflammation for many autoimmune disorders and are a specific target in the case of IIM. Multiple JAK inhibitors are available with limited evidence, but appear promising in severe refractory cases of disease, in particular for skin disease, as Dr. Worth has outlined, and interstitial lung disease. Second-generation drugs are more targeted to JAK1, which may be critical in limiting the side effects seen in first-generation drugs. Outcomes in pediatrics are not predicated on evaluation by many, if any, standardized metrics, and are only case series level data. And I think that's really important to understand. We don't know exactly where these medicines fit best in the hierarchy of medication use and what phenotypes they might best be suited for, in particular in pediatrics. Trials in adult data have been small and many safety questions still exist. In particular, when you're thinking about puberty and growth and development, especially in young children, like I said, the average age of reported use in JAK inhibitors was the age of 5 in this most recent outline. Implications are important, especially when you're considering use of JAK2 inhibition, which interacts with growth hormones and prolactin. And again, definition for improvement varied among the reports, and dosing has yet to be well outlined. I'd like to give a shout out to Mark Jansen for highlighting the trial of baricitinib and JDM recruiting in France currently. And there are some important resources, and I'm happy to take any questions.
Thank you, Stacey. One question's come up in the chat box already from Suzanne. What do you think might be a way to look at newer JAKs and TYK2 in our JM kids case series versus clinical trials?
Yeah, I mean, I think that clinical trials is always something that we would like to manifest, right? I'll use my teenagers' terms. That's the best way for us to understand clearly if these medications are working well, the best way to outline what considerations we should have in terms of the patient-specific phenotypes we should be using these medications for, and would best outline for our families some critical questions that Polly brought up in her talk, which is, what are the risks? What are the risks to my kids? What are the risks long-term for my kids? Do these medicines cause cancer? Should these medicines be used in patients who are prepubertal? What happens with growth and development in my children? Those are all critical things that we haven't been able to answer, as these drugs are relatively newly used on the market, and are going to be important questions to answer that it's hard as a clinical person sitting in front of a patient to say, I don't know, which means I think clinical trials are our best option because they can give us a little bit clearer information than case reports.
I think following on from that, I mean, obviously clinical trials would be the gold standard, but as the foundation has funded several repositories and registries of samples, as you would know from your role in CARA, and I know the foundation has had some internal navel gazing as to how much data is actually out there, either in biorepositories that are just collected at a local hospital or a local site to answer their own research questions, and the CARA biorepository. I mean, given that these drugs are relatively new, but some of these biorepositories have now only been going for a few years, it's like, is there a sample set out there that is already available that could be interrogated that may help answer some of those initial questions and help guide a clinical trial? It's something that would be, I know the foundation will be extremely interested in figuring out if there's a way that some people could collaborate and access that resource that's already out there.
I can comment a little bit on the CARA registry because we've been interrogating a lot of the registry data, looking at the use of CTPs, but just looking at the data in general. And as many of you know, the CARA registry cohort is a very valuable cohort, not only because of the number of patients that are in it, but also because it's an inception cohort. And so fortunately it is that, but unfortunately it takes a period of time for patients to move through some of the initial recognized more standard of care therapies, if you will, before moving on to some of these newer therapies. And so there are not a ton of these patients in the registry at present. There are a few, but not enough to say a lot about. But it's important that we keep collecting this data. And one initiative that I think really our Cara and Press lupus groups has done and is really admirable is ensuring that, and I will say that the JDM groups have done this to a certain extent, ensuring that our respective databases are collecting the same materials so that in a large cohort, we could combine forces, if you will, to be able to answer some of those really important questions that you're asking about, Andrew. I did see a question in the chat from Lucy Wedderburn, or a comment, and thank you. What I'll say about that is that a lot of information we have, because I was reflecting on this myself, is in tofacitinib, right? And tofacitinib is a JAK1/3 more specific inhibitor with less JAK2 activity. And so in that instance, I don't know that we know a lot about what happens with puberty and growth and development, because tofacitinib is the medicine that we have a lot of information about, and not as much about baricitinib or ruxolitinib that have more activity in those drugs. So I think it's going to be important to continue to flesh out that story moving forward.
There's another question in the chat box. Do you use interferon signature to guide treatment stopping or not in spite of clinical condition?
Oh gosh, so I'm a big believer in you look at the entire patient, and that includes what their labs show you and what they show you sitting in front of you in the room. So what I would tell you is that, yes, we sometimes use cytokine panels and interferon signature with a patient sitting in front of you in the room. But I think Dr. Jansen highlighted that they don't always correlate well with what you're seeing with a patient in the room. We don't know how exactly predictive they may be. That his group and others are doing really important work to hopefully answer some of those questions for us. But does it make me nervous when I see those things? Absolutely. Do I watch my patients maybe a little bit closer and maybe look a little bit harder and think about more significance in the clinical and other lab findings that I'm seeing? Yes, I do.
There's another question in the chat box from Lucy. I think it's a comment
about the core data set.
Yeah.
What I'll say is that, at least in our Cara registry data, one thing that we're finding that really limits us is the total improvement score variables are not consistently well collected. And so our therapeutics group, including Kaveh Ardalan, Matt Sherman, who presented before me, are really focused, in addition with our press colleagues, to try to get a minimal data set and to look critically at the total improvement score components to say, we want to collect that data. We want to make sure that we have that data collected in a systematic and thorough way. And that's one barrier that we really need to overcome within that Cara data set, that we're ready to take on that challenge.
We might wrap it up at that stage. Stacey, thank you for helping us unravel that complex interplay of the interferons and the interferon pathway and all the JAK stats and the TYK2s. I think it's something that we're obviously keeping a watching eye on and looking for leadership from our MAB as to what the progress is on those important drugs.